Nishit is with us only now, and so is
Okay.
Gautam.
Okay, great. Great, sir.
Nishit, you and what is Sneha are the batch, right? Same batch, right?
Yes, Neha, me and Nishit. Sir, you forgot us, sir.
No, no, I didn't forget. I'm just reconfirming. See,
Sir.
age
Yes,
is
sir.
catching up, Gayatri. So sometimes it's always good to reconfirm.
Yes.
So we'll start on time. Okay.
Yes, sir. Yes, sir.
Sure, sir. So Savina ma'am yet to join. She will be joining shortly.
That's okay. See, the topics are not sequential. So you can always, go as per the first come first serve basis also. So we can just prepone by one thing if it is required.
Okay, sir.
Right. So 7:05 we are 7 o'clock sharp. We'll start the introduction, and then just we will wait for the others to join. Right?
Yes, sir.
Yeah. Another 3 minutes. We'll log in. Hi, good evening, everyone. Welcome to today's topic, that is the expert insights in the lung cancer. For a change, this is completely academic, not sponsored by any pharma, absolute zero finances involved. So I'm so refreshing and very good to be moderating such a session. for a change, that is the International Association of Integrated Oncology, you call as a IAIO, is conducting this great academic session where we have five speakers. Dr. Sabina K. Chaudhary, a consultant medical oncologist at Rajiv Gandhi Cancer Institute and Research Center, Delhi. Then Dr. Gayatri from Mumbai, Sunrise Oncology, consultant medical oncologist again. And we have Dr. Srinath Bharadwaj, a consultant medical oncologist and hematologist at American Oncology Institute, Hyderabad, my colleague. And Dr. Abhinav Diwan from RGCIR Delhi again. He's a medical oncologist. And Dr. Rekha Bansal, finally from Apollo Hyderabad. So lung cancer, we have been hearing a lot of new molecules coming up and then down. So we have curated five topics with the help of the experts. That is molecular profiling in NSCLC beyond EGFR and ALK. So we know EGFR and ALK, but what is beyond that is what Dr. Sabina is going to speak. This is followed by immunotherapy optimization. Who responds, who doesn't respond, and why it happens so. That will be taken by Dr. Gayatri. Then we are going to discuss about the advances in early stage lung cancer, whether to go for surgery, SBRT, and what are the adjuvant strategies. Probably Dr. Sainath is best placed because he is having a knowledge of best of both radiation and medical. And then we are going to discuss targeting resistance, especially for the EGFR, RAS, and other things with the newer molecules, where Dr. Abhinav is going to take it. And probably one of the very toughest topics, that is small cell lung cancer resistance, how we are going to deal the chemotherapy and then how we are going to integrate immunotherapy, will be spoken by Dr. Rekha Bansal. With the flood of molecules which is coming up with the ever changing guidelines, I think it is worth exploring these things. Over to the organizers to take this to the next steps.
Sure, sir. So, Sabina ma'am yet to join. Actually, she
We
trouble.
will go with Dr. Gayatri, and when Dr. Sabina joins, we'll just come back to her in that case.
Okay, okay, fine, sir.
Right, bye.
Then,
I'll share my slides.
yeah, sure, ma'am.
Yeah, just a moment.
Then it's now my pleasure to invite Dr. Gayatri Raheja, consultant medical oncologist, Sunrise Oncology, Mumbai. Ma'am, the virtual stage is yours. Please start.
Yeah, just help me share the slides. That's all. 1 minute.
Yes, ma'am.
Is it shared? Hello?
Not yet, ma'am.
Uh, that column is not coming, only share karke. Can you?
Can we share?
Yeah, please share. No,
Yeah, please.
I mean, I don't know. 1 minute. Just let me try again from my side. Why is
Okay.
that column not coming of share slide?
Yeah, share slide.
Okay, you share it then.
Okay, okay, ma'am. Fine.
Let me know once you've shared it.
Yes, sure, ma'am. It's visible, ma'am.
1 minute, I'll just yeah, now can you see? I have shared it. Can you see it?
No, ma'am. Actually, I
Okay, then you don't. Okay, share it, please.
Yes, already shared, ma'am. It's
Okay,
visible.
coming to, yeah.
Yeah.
So, speaking about optimizing immunotherapy in lung cancer. So, here we are seeing the interactions of various biomarkers such as PDL1, tumor mutation burden, STK11, KEAP1 mutation, KRAS, TP53, and gene expression signature, because there is an interaction of all these biomarkers, whereas in we have to decide on the treatment. So, coming to the first uh, thing about understanding the cancer immunity cycle, it is about antigen release followed by antigen presentation, then T cell priming, T cell trafficking, tumor infiltration, antigen recognition, and then tumor cell killing. So, coming to the mechanism of CTL4 functioning, we all know that when CTLA4 is blocked, there is unopposed CD28 co-stimulation, and because of which there is broader T cell priming and clonal diversity. So, this is the mechanism of action where we see of CTLA4 blockage. Now, this is coming into very much importance because now when we are talking about these rare mutations such as CTK11 and KEAP1, the role of CTLA4 blockade is very much into the picture. And we see here that the biomarker association, when it is PD-L1 blockage, it is about PD-L1 expression, tumor mutation burden, T cell inflammation, gene effector profiling. But when it is, we are dealing with STK11 and KEAP1 mutation, the PD-L1 is less available for being blocked, and there are other factors which are coming into picture. So this is the column where there is a difference between PD-L1 blockage and CTLA4 blockage, where we are clearly seeing that PD-L1 blockage is depending on the tumor microenvironment peripherally, and CTL4A blockage is on lymph node
Ma'am,
central priming.
sorry to
Yes.
interrupt. Actually, you have to tell us next slide, when to change the slide.
No, actually, my slides are going up, and I don't know why the thing is. Please go on slide number 10.
Okay.
Correct? Are we on slide number 10?
Yes,
So
ma'am.
the co-occurring genomic alterations of CTK11 keep one TP53 mutation and KRAS becomes very important. For example, if CTK11 is coexisting with TP53, then the prognosis is slightly better compared to if the CTK11 is with KRAS. So CTK11 with KRAS would be a worse prognosis compared to CTK11 with TP53. So this combination of what exists is very important for deciding what the prognosis would
Sorry,
be.
ma'am. Your slide is
So
not
slide number
visible.
11.
Yeah.
Slide number 11.
Okay.
Yeah. So as we all know that PD-L1 blockers such as monotherapy is used when PD-L1 is more than 50%, and when it is between 1 to 49%, we're using chemo IO, and less than 1% also we are using chemo IO. That was the previous thing. Now, tumor mutational burden is correlates with the presence of neoantigens, and is one of the main important factors when we come to PD-L1 blockers. But 13, slide number 13. When we are talking about STK11 mutation, it is a cold tumor driver, because what happens is when the STK11 mutation happens, the microenvironment is cold. And because of the cold phenotype, the CD8 T infiltration does not take place. So there is reduced CD8 T infiltration, and there is increased neutrophil interleukin 6 to 8 driven myeloid infiltration. So all of this causes the immunotherapy not to work so properly in the CTK11 mutation. Are we on 13th? Hello? 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 Hello?
Yes, ma'am.
Yeah, are we on 13th slide? Okay, so coming to the slide number 14,
Ma'am,
the
you said next,
STK
next. Ma'am.
next. Okay,
Yeah, then we
yes.
will do.
So
Yeah.
the STK11 mutation, it is a tumor suppressor kinase upstream uh, inhibitor, like it is acting on the mTOR signaling. And because it is acting on the mTOR signaling, there is regulating cellular energy, metabolism, and polarity. So due to this, again, the PDL1 will not function. So this STK1 is encoding for liver kinase B1. Next, slide number 14. Now coming to the KEAP1 mutation. Are we on the same page? KEAP1 mutation? Hello?
Yes. Yes, ma'am.
Yeah, so KEAP1 mutation is acting on the NRF2 pathway. So it is acting on the NRF2 pathway and dysregulating it. So when the NRF2 pathway is dysregulated, there is oxidative stress response. And because of the oxidative stress response and because of the cellular hemostasis getting affected, again, this is one of the factors due to which there is cold microenvironment and the PDL1 inhibitors will not work so well. Next, coming to KRAS and TP53 co-mutational subtyping. So, the practical rule is always that whether KRAS and TP53 jointly existing with CTK11 keep one status. Because we already discussed that when like CTK11 coexisting with P53 is still a better prognosis compared to CTK11 coexisting with KRAS. So coming again to the tumor, next slide number 16. Coming to the tumor microenvironment. So whether a immunotherapy is working or not, it very much depends on the tumor microenvironment, whether it is a hot tumor microenvironment, cold one, or excluded phenotypes. So when it is a hot tumor microenvironment, so that means that the CD plus T cells, CD8 plus T cells can very well infiltrate into the lung parenchyma and cause the blockage. And when it is a cold microenvironment, as we see in CTK1 mutation, 11 mutation, the infiltration of the T cells cannot take place. So the microenvironment, hot and cold, is very important. Coming to next, gene expression, slide number 17. So now as I already said that gene expression signature, for example, T cell infiltrated gene expression profile, which is related to interferon alpha. This is very important because when this is good, the PDL1 expression is good and the immunotherapy works well. So as we already said that PDL1 works well, inhibitors work well when the gene expression signatures are good. Coming to my next slide, slide number 18. The circulatory biomarkers and marker response. So now we are coming and understanding the mechanism of resistance. Slide number 20, please. Primary resistance. So how does primary resistance occur? There is low antigenicity, then there is antigen presentation loss, then there is oncogenic signaling goof up, after which there could be immune excluded desertment and myeloid driven suppression, and host systemic factors also play a role. So all this is going to cause a mechanism of primary resistance. Now coming to the mechanism of secondary resistance, slide number 21. There is antigen loss which causes editing. Then there is beta 2 microglobulin loss, and there is alteration in the checkpoint upregulation. The T cells get exhausted, the micro environment gets remodeled. So the ultimately what is happening, micro environment is the main important thing for the mechanism of drugs to work. That gets remodeled, and this causes the acquired resistance. Next slide, please. Slide number 22. We are on slide number 22. So we initially saw that monotherapy with immunotherapy in Keynote 024 and Empower Lung 1. Then we saw that chemo plus IO in Keynote 189 and Keynote 407. Then we saw dual checkpoint plus chemo in Checkmate 227 and Checkmate 9LA. And now we have come to the era of Poseidon, which I'm going to explain, because in Poseidon trial, we are taking temililumab and we are taking durvalumab so that we can act on these rare mutations such as CTK11 and KEAP1 mutation. So, so all the keynote trials we'll be discussing in short. Then coming to checkpoint 227, checkmate 9LA, and then finally coming to Poseidon trial, which we are going to discuss. Coming to next slide, slide number 23. Okay, so keynote 024, we very well saw that the median PFS in the monotherapy arm was 10.9 months versus 6 months in the chemotherapy arm. Then in the next keynote, next slide please, keynote 042, we saw that there was pembrolizumab arm giving 20 months versus 12.2 months in the chemotherapy arm. Then we had the keynote 189. Next slide please, slide number 25. We had the median OS of 22 months in the pembrolizumab plus chemo arm versus 10.6 months in the chemo alone arm. Then we had the keynote 407, next slide please, where we had pembrolizumab plus chemo giving 17.2 months versus chemo alone arm, which is 11.6 months. Then came the checkmate 9LA, where we had Nivo plus EP plus 2 cycles of chemo, which gave 15.6 months versus chemo alone giving 10.9 months. Then we came to the era of checkmate 227, which is chemo-free, nivolumab plus epilumumab, giving a median overall survival of 17.1 months versus only chemo, which is 14.9 months. And now, where I'm coming to Poseidon. Ma'am, for Poseidon is slide number 29. This is giving, this in Poseidon, we are giving tremelimumab plus durvalumab. So, tremelimumab is CTLA4 inhibitor plus durvalumab plus chemotherapy. This is the treatment which is designed for places where PD-L1 high or low, irrespective of that. If CTK11 and KEAP1 or KRAS, all these mutations are giving poor prognosis to immunotherapy. So the Poseidon comes here into the picture, where the combination of these three, which is tremelimumab plus durvalumab plus chemotherapy, is giving 14 months versus 11.7 months in the chemo arm. And even in the if you alone take STK11 mutated patients, the 5-year overall survival is 12.9% versus 0%. So this is what the Poseidon is a very big eye opener. Then coming to discuss, ma'am, slide number 30, Empower Lung 1 and 3, which is semiplimab based chemotherapy. So Empower Lung 1, we had which is a phase 3 trial where PD-L1 was more than 50%, and semiplimab arm was giving 26.1 months of median overall survival versus 13.3 months in the control arm. So, and this trial which I am discussing now is a very important trial because this is the Ipsos trial. Now, in the Ipsos trial is meant for people who are ineligible patients. For example, ineligible like they have heart failure, they have CKD, they are having a poor performance status, and they are aged people, like for example 79-year-old in age. Ma'am, slide number 31. So these people with a poor performance status, CKD status, heart failure, you can give single agent monotherapy of atezolizumab, which is giving a median overall survival of 10.3 months versus chemotherapy giving 9.2 months. So this is the Ipsos trial. So this, ma'am, slide number 32. This is the hazard ratio of the various trials which I discussed: Keynote 024, 042, 189, Keynote 407, Checkmate 9LA, Checkmate 227, and the Poseidon. Ma'am, are you on 32? Hello?
Yes,
Hello?
ma'am. Yes, ma'am.
You're on
You're
32?
32. Yes, yes.
Yeah. Now we have the, so now we want to discuss, since I'm running short of time, how much time do I have, ma'am?
Yes, ma'am. Sorry.
How much time do I have?
Your time. 1 second, ma'am.
Okay, please take on slide
7:20.
number 36. Please take on
Yes,
slide
yes,
number
yes.
36. So, so giving a clear picture that once there is, we confirm that EGFR, ALK, ROS1 is absent, and we see that PDL1 is more than 50%, we go for IO immunotherapy, monotherapy. If PDL1 is between 1 to 49% with high tumor burden, we are going for chemo IO, that we know. Now, what by the Checkmate 227 and 9LA and the Poseidon, this is useful when we have the CTK11 and KEAP1 mutation, or the KRAS mutation with STK11 mutation. So that is slide number 36. Now coming to the molecular biology of two cold tumor pathways. So slide number 37. Here we are again discussing how the CTK11 is, initiating, activating the AMPK, and the mTOR pathway is getting affected here, and the KEAP1 mutation getting affected. The NRF2 pathway causing oxidative stress is getting affected. And in either both the ways, both the things will cause the microenvironment to be the cold type. Next slide. So coming to, I have 5 case scenarios which I would like to discuss. Okay, before that, we will just go to slide number 40, where coming to the case scenario, the first case scenario, can we have an interactive session now for the case scenario?
Uh, Ma'am, slide number 40.
1 minute.
Future strategies for STK11.
One
This
minute,
one?
just a moment. Let me take it to the slide, ma'am. Slide number 49.
Yes.
62-year-old former smoker, newly diagnosed stage 4B lung adenocarcinoma, multiple liver mets, ECOG performance status of 1, NGS KRAS G12C, STK11 co-mutation, TP53 wild type, and PDL1 TPS 80%. So what would be the plan of management? Hello?
Yes, ma'am.
Yeah, can the people around just be there to tell what would be the plan of management here?
You can ask faculties because attendees not respond in voice.
Sir, sir, Suresh sir? Hello? Hello?
Suresh sir is not there, ma'am. Abhinav sir there, Savina ma'am there, and Srinath sir there.
Okay. So 62-year-old former smoker with newly diagnosed stage 4B lung adenocarcinoma, multiple liver mets, ECOG performance status of 1, NGS KRAS G12C, CTK11 co-mutation, and TP53 wild type, and PDL1 TPS 80%. So what would be the plan according to you all?
It should be actually
Are we on slide
chemotherapy
number
plus
49?
immunotherapy both.
Yeah,
IoT
correct. And what about trying tremelimumab plus durvalumab plus chemo?
So is
Hello?
in the given scenario, we would generally, as an institute, we usually go for immunotherapy plus
Correct.
chemotherapy for a good
Correct. We would go
response.
for that. Okay. So next case scenario, 58-year-old. Next slide, please. 58-year-old current smoker, stage 4 lung adenocarcinoma, bone and adrenal metastasis, ECOG performance status 1, and the NGS is showing KEAP1 mutation, TP53 mutation, and TPS of 70%. So what would you like to do here?
Ma'am, audience can answer in chat. So if you are,
I'm not being able to see the chat. Let them speak up, no?
yeah.
So because KEAP1 mutation is there, there'll be chemo IO resistance. There is co-occurring of TP53 mutation without STK11, right? So here can we use
In this scenario, I
tremelimumab plus
think
durvalumab
the
plus
durva-tremi will be a good option. Durva-tremi along with chemo will be a good option.
Yes.
So we need
So
CTLA4
going to the
intensification in this case.
yes, absolutely. Going to the next case scenario. Okay. Slide number 51. So a 55-year-old never smoker, lung adenocarcinoma, PDL1 with TPS score 2%, tumor burden of 14, mutation, and STK11 and KEAP1 wild type with moderate disease burden. So an ECOG performance status of 0. So here, what would you like to do?
Ma'am, sorry to interrupt. 2 more minutes left for your session.
Yeah, I'm just ending. So can we last 2 cases to be discussed? Yeah. So can you somebody tell what can be done here? The same ma'am who was discussing with me, please. Hello. Hello.
Hello. Yeah.
Yeah, please.
So, since she's a never smoker and it'll be pembro chemo followed by maintenance. I think.
Beautiful. Because here the CTK11 and KEAP1 is wild type. So we have a hot microenvironment, and when we have a hot microenvironment, and the tumor mutation burden is good, we will go for pembro and this. And this is the last case scenario. I'll skip this because we have less time. Now, 79-year-old, okay, multiple comorbidities, CKD3, mild heart failure, 53 slide number, please. Okay, 79-year-old, I said, CKD stage 3, mild heart failure, newly diagnosed stage 4. Okay, ECOG performance status is 2 and TPS score is 45%. Same lady who answered me, can you please help me again? What can be done? Hello? Yeah.
Multiple comorbidities are there. 79, right?
Yes, boss. 79 CKD. I already told it in my darling. I already told it
In
in
this
my
case,
talk.
I think we can use the Ipsos study, like Atizo we can use.
Beautiful. What's your good name?
I'm Dr. Sabina. I work in Rajiv Gandhi Cancer
I think you
Institute.
were only listening to me. Okay, yeah. So we go by atezolizumab. So I finished with this.
Yeah.
So I think I was clear enough in share. Like we discussed all the keynotes, the checkmate, the poisadon, and the hot environment, the cold environment, the STK11 mutational pathway, the keep1 pathway, and all the microenvironments. I hope this went well. There was a problem with sharing my slides, but I think I was loud and clear enough. Thank you so much.
Thank you, ma'am. Thank you for those insightful presentation.
Yeah. Yes, boss. Thank you.
Can I start?
Hello.
Hello. Yeah.
It's my pleasure
Am
to
I audible?
invite Dr. Savina K. Chaudhary, ma'am, consultant medical oncologist, Rajiv Gandhi Cancer Center Research Center. Ma'am, over to you.
Yeah, I'll try to make it as quick as possible. So,
Yes, ma'am.
I'm sorry, my talk was postponed because of some technical glitch. So, good evening, everyone. Thank you to the organizers for this invitation. So, as we all know, precision oncology has totally transformed the NSCLC over the last decade. So, now our challenge is no longer identifying the actionable mutations. We have plenty amount of validated targets and effective therapies. The challenge currently is we have to ensure that we identify them quickly enough to make the right first decision. So today, next slide, please.
Ma'am,
I can't see my slide only now.
yes, ma'am. Can we share?
Just share the first slide, the roadmap slide.
Yeah, sure.
Yeah.
Just give me 2 minutes, ma'am. I'll share.
Yeah, sure.
Even I was unable to share from my side. It was, I don't know what was the problem.
Dr. Avius is there?
No, ma'am.
Okay. Yeah, next slide.
It's visible, ma'am.
Yeah.
Yeah.
Next slide.
Yeah.
Yeah, so this will be the roadmap for the next 10-15 minutes. So I'll not be reviewing. Next slide. Yeah. So rather than reviewing, this is the landscape on 2026. So, so molecular testing is no longer confined to the metastatic disease. So can you share the previous slide once? I'm not able to see the slide only. Is it on screen share mode? I can't see. Yeah.
Visible, ma'am?
Yes, yes. Now it is
Okay.
visible. Yes, now I can see. Next slide, please. Yeah. So around 60 to 70% of the adenocarcinomas, non-squamous carcinomas, they harbor actionable drivers. So not actionable, they harbor some driver mutations. So testing is now even important in not only in advanced stages, it is even important in early stages. So recently, around in 2025, some 7 new FDA approvals were there. So molecular testing, one thing is you have to do not only the advanced settings, also in the early settings, wherein when you give surgery, when you do surgery, then also you can do an adjuvant treatment therapy based on the targets available. Like for example, adjuvant osimertinib, adjuvant alectinib, and more recently, I think selpercatinib also, as per the Libretto trial, is gaining adjuvant treatment recommendations. So across all stages, we need driver mutations testings. Another important point in our Indian setup is EGFR mutations, which is even so. If you see the Western population, the squamous cell carcinomas, they have around 1% population. They will have EGFR mutations, whereas in India scenario, around 5%, less than 5% people in squamous cell carcinomas also they harbor EGFR mutations. So I think with in squamous, we should go by a case to case basis whether to do a complete NGS or not. Next slide. I'll not go through the full slide. Just to tell you something on the EGFR, that now we have mature OS data both from the FLORA-2 and the Mariposa, which supports the first-line treatment intensification. Like not only osimertinib, along with osimertinib, we use chemotherapy as per the FLORA-2 trial if a patient has co-mutations or brain mets or liver mets. Generally, so co-mutations are important for treatment intensification. So it is not just the EGFR. Knowing EGFR, we need to do a full NGS to know what other mutations the patient is carrying. Then ALK, knowing the ALK status also, adjuvant alectinib after the ELINA trial has changed the full practice, even in early stage. Libretto, I already mentioned in RET. So RET also, it has moved the RET testing from advanced into the early stage. Similarly, HER2 also has rapidly evolved with the TDXT and the newer TKIs. So the message here, I would say, is not in memorizing these drugs. The important message that I want to give is that every year new biomarkers become clinically actionable, and thereby making comprehensive testing increasingly necessary for every patient. Next slide, please. So this is a common misconception that only NGS is important. So NGS cannot replace IHC, it cannot replace FISH. Each answers a different biological question. Like IHC will detect a protein expression, FISH detects amplifications or rearrangements, and NGS is what detects mutations and gene fusions. So a normal NGS report will not exclude a MET overexpression. So you can know the MET 13, 15, that skipping mutation, you can know on NGS, but MET overexpression, you will be able to know only by IHC. Similarly, HER2 overexpression. HER2 mutation is okay, but HER2 overexpression, you will come to know only when the protein is checked. So these tests remain protein-based biomarkers like MET overexpression and HER2 overexpression. Next slide. Okay, so NGS versus single gene. This is one thing I will tell. So imagine you are searching your wardrobe only for a blue shirt. So if you don't find any blue shirt, that doesn't mean that the wardrobe is empty. Likewise, when you have a negative EGFR PCR, it tells us nothing about ALK, RET, MET, HER2, KRAS, or any other biomarker. It is not telling us any. So we are not looking for those. So it doesn't mean that it is not there. So NGS should be a standard for metastatic NSCLCs. When there is a limited tissue, when you cannot do each test individually, then it is better to do an NGS. Then if you want to check for multiple biomarkers, then NGS should be a standard. Single gene testing remains useful for a rapid confirmation, or when a disease has progressed and you want to test when the pre-test probability is very high. Suppose a patient is on a first generation or second generation TKI, EGFR TKI, and the patient has progressed, then you will be specifically looking for a T790M mutation. So that is when you will prefer a single gene testing. Or if it's a resource limiting setting that you don't have access to NGS, in that case you can do single gene testing, like specifically, like you can test for EGFR, then you can test for ALK, ROS, like that. So ideally NGS should be a standard. Next slide, please. So when you talk about the liquid versus tissue, when you talk about liquid versus tissue, the simple rule is that at diagnosis, we need tissue. So at diagnosis, tissue is a must. Liquid biopsy is a complementary test. It is not the only. So nothing is superior over the other. But in general, when we do at diagnosis, we definitely want a tissue first. And at progression, the dictum is you can go for a plasma first, and you will do tissue at progression only if suppose plasma is negative, because at progression, if plasma is negative, will not rule out that nothing is there. So the dictum, tissue first at diagnosis, plasma first at progression. But otherwise, both are complementary to each other. One can miss what the other finds out. So next slide, please. Yeah, so this is the like evidence behind the liquid biopsy. There were certain trials like Nile study. It showed that if you add along with tissue NGS, you do a liquid biopsy at the baseline. Because of that, there was a increased biomarker detection by around 48%. So adding liquid biopsy to a tissue biopsy at diagnosis, you can increase your biomarker detection by 48%. Plus the TAT will be low. around 9 days in liquid biopsy versus 15 to 21 days in tissue-based NGS. And response rates, and they also check the response rates, like with plasma guided therapy was approximately 58% because it is an early test at that. So then plasma, can miss the main disadvantage that we see is that liquid biopsy, when you check blood, if the tumor is a low shedding tumor or if it is confined only to the brain, in those cases you can miss many ctDNAs, like many mutations on the plasma. It can come as a false negative test. Therefore, a negative plasma result should never be considered truly negative until and unless we prove it by a tissue biopsy. Next slide, please. So the real world problem is the turnaround time. So this is mainly about the systems, not the biology of the tumor. So usually we want a maximum 10 working days should be the TAT. But in reality, if you see at your own centers also, it nearly takes 3 weeks for the NGS final report to come. So these delays have real consequences. The patients may start chemotherapy or immunotherapy. At many centers, immunotherapy gets started because the NGS will take time. So even before the molecular results return, the patients would have been started on chemotherapy or even immunotherapy. So they lose that opportunity to receive an optimal first line targeted therapy. And many times it can be even detrimental. So suppose you have given immunotherapy to a patient who turns out to be EGFR positive. You cannot give, as per the many studies have shown, that when you give osimertinib immediately after immunotherapy, there can be increased chances of pneumonitis or even any more toxicity. Immune related toxicity can be more if you give osimertinib, especially within 3 months of giving your immunotherapy. So all these things are the flaws of starting of delayed TAT. Next slide, please. So treatment initiation, what every oncologist will face this situation, that a patient is symptomatic, your molecular report is pending, should we wait, or what to do? So answer is, I think if the patient is stable, we can wait, but the patient anxiety and all, or the patient is unstable, I think we should go with empirical chemotherapy first, histology based. We should avoid giving empiric immunotherapy. That would be my take on this. This was the question that was given to me to answer. So we should avoid empiric immunotherapy if the patient is unstable or the relatives are very anxious, because this is usually the scenarios. We cannot tell them to wait till the final report comes. So we can start with chemotherapy alone. So again, the example that I gave, like if you start immunotherapy, you cannot give your targeted therapy within 3 months or so because of increased chances of severe immune related toxicity. So if you cannot truly wait, you start chemotherapy alone. Simultaneously, you can just expedite your molecular testing reports. Next slide, please. So okay, so I would say these are the reflex testing is important. That when the patient comes, like in our institute, we generally do a reflex testing for EGFR. Once we know the diagnosis is adenocarcinoma, especially, we send it for reflex testing immediately, and we take a liquid biopsy for EGFR, and we do an IHC on for ALK. These are the two reflex testings generally we do in non-smokers and adenocarcinomas. And simultaneously, you can give the tissue for NGS, and this is a bridging testing that you can do. It is institution based. Like we have in our institute, we do a reflex testing and then we wait for the NGS reports. If nothing comes out on the reflex testing, we do an NGS and wait for the NGS for starting the immunotherapy. Next slide, please. Next slide. So again, if the patient is deteriorating, this was another question that was told to me to answer in this talk. So if a patient is deteriorating, so I would suggest a 5-step approach. First, we should exclude all the reversible causes. We should expedite all the rapid biomarkers that we can do. And as I said, we should start chemotherapy alone if the treatment cannot wait and other reversible causes have been ruled out. We should send an immediate liquid biopsy for PCRs. And if a biopsy has been done, we should do at least the minimum possible, like ALK. And of course, we can discuss an MDT, like what next to be done. So this is what we usually do. Next slide, please. Yeah, so take home points, if you just have to remember 5 things, I think molecular testing is the dictum we have to do for all NSCLC patients, be it squamous should be a physician choice, and non-squamous, I think we should do it for all. We do it NGS. Generally, we have a smart lung panel that we use for all the lung cancer patients. Then comprehensive NGS should be our default. Tissue and plasma are complementary. Nothing is superior over the other. But if you have to talk about only about tissue, I think copy number gain, fusions, these are some things that you can get on tissue better than liquid, because in liquid we are just checking the DNA and RNA as a both. So we will not get enough, many times we will not get enough cells for that testing copy number or fusions. So this is, and turnaround time also directly affects the outcome. So turnaround time should be less as possible. So that's it. Thank you. I would be happy to take any questions. These are the references that I took for. Thank you.
Thank you, ma'am. Thank you for excellent and informative presentation. So
Is it
we
on?
now
Is it on
move
my
to
doctor
our,
now?
yes, we move to our third presentation. Our next speaker is Dr. Srinath Bharadwaj,
Okay. No,
consultant
yeah,
medical
yeah, this one, yeah.
oncologist and hematologist, American Oncology Institute, Hyderabad. May I
So,
request Dr. Srinath Bharadwaj, sir, to kindly begin his presentation?
yeah.
Yeah.
I'm sharing my screen.
Yeah, sure, sir.
Yeah, it's visible?
So not yet. Your slide is not visible.
No, slide, no, screen. Screen is visible.
Screen is visible, yes.
1 second.1 second. Right. So my presentation is visible?
No, sir, not visible.
Okay.
Actually, sir, the same thing happened with me. I think only when they are sharing, we can see.
How is it?
So we
Yeah,
could
I had a
see your
terrible problem.
screen. Yes, ma'am. But then we could see sir's the shared screen. But then the presentation tab was behind, sir. Maybe if you can just try once again.
Okay, I'll just check. Yeah, I mean, the screen is getting locked once I share. I don't understand that.
Screen was quite
Same,
visible.
same thing happened with
Oh,
me.
yeah.
So screen is getting locked when I share, and when I cancel again, that thing is going away. So it's not knowing how to. Yeah.
Now,
So
so yeah, we can see
what are you seeing now?
the collapsed window of Zoom and your, I mean, we can see you as well. And the presentations
Now?
are behind. Yeah, now the presentation,
Now?
yeah, but it's not on full screen
Okay.
because the it is cutting away. Maybe if we can share the screen.
Maybe I had some smaller changes. I'll check.
Okay.
Usually this doesn't happen. I don't know why it's happening.
Yeah, I mean, all the rights are there with the speakers to share the screen
Mhm.
and everything. Yeah.
No, my point is, why is my screen getting locked if I share it? That is the thing. Your browser is preventing access to your share screen. That's what it's saying.
Which browser you're using, sir? Maybe you can.
Using Safari.
Safari. It doesn't happen on Safari either. Any possibility if you can change the browser?
I have to log out and log in that case.
Okay. Then maybe you can send us your updated slides. We can share, or the ones we have, we can share that. If that's not a big change.
Okay. So put it on WhatsApp.
Sure, sir.
Put it on WhatsApp. Yeah. Put it on WhatsApp.
Okay, sir. Just give us 2 minutes. We'll just download and post it.
Yeah.
Visible now, sir?
Yeah.
Okay. So while we move on, you can just say next and I'll move on to the next slide.
Sure. So quite a long topic. Thank you, Dr. Suresh sir, and IIO for this opportunity. Literally, I'm starting from screening lung cancer data to 3A, stage 1 to stage 3A management, and maybe operable stage 3B. So quite a longer, but I'll try to be very precise and not take too long time. So quickly starting with screening and its evidence and the gaps in screening. Next slide, please. So the evidence, who qualifies, and closing the screening gap is what the organizers wanted me to speak on. Next one. So why do we screen first of all? Because a lethal, it's a lethal if it's caught lately, and it's the leading cause of cancer death in the United States, more than colon, breast, and prostate combined, and around roughly 125,000 deaths per year. Estimated US lung cancer deaths annually is like 225,000. And the 5-year survival is around 20% if it is detected late, and early versus late, the 5-year survivals drop from 60 to 6%. Next, please. So two landmark trials, actually National Lung Screening Trial and the Nelson Trial, have clearly shown that there was a 20 to 24% reduction in mortality if we are able to screen. And they're randomized controlled trials. So we have definite evidence that low-dose CT screening will reduce mortality. Next one, please. So who qualifies for annual low-dose CT? 50 to 80 years of age, more than or equal to 20 pack year history, and less than or equal to 15 years since quitting, or a current smoker. And slowly, if you see, the guidelines have kind of broadened the inclusivity, and hence the population who can be screened. And currently 12.8 million US adults currently eligible under the US PSTF criteria, and an estimated 28 million ever smokers aged between 50 to 80 fall just outside today's thresholds. Next, please. So does this evidence fit India, or are we looking at a different disease pattern? So definitely the kind of patients we see are fairly different from what we see in the West. 40 to 50% Indian lung cancer patients are never smokers, and up to 83% of women are never smokers. So 54 years is the median age of diagnosis, a decade younger than the West, and 80 to 85% present with advanced incurable phase of the disease. Only 5 to 15% undergo curative or surgical management, and roughly we see 81,748 new cases in a year and 75,000 deaths per year. That's the GloboCan 2022 data. And unfortunately, we don't have a national LDCT screening program like the United States. A Mumbai LDCT pilot found nodules in 93%, and the Indian lung cancer screening trial AIMS is launching. So ICMR and Tata Memorial urge risk-based screening turn to Indian risk. Next, please. So the screening gap you see, lung cancer we're only screening 20%, whereas breast, cervical, and colorectal roughly stand between 65 to 70%. And this is all US data, including US. It is a very sad state of affairs when it comes to lung cancer screening. Next, please. So why the gap persists? Because a lot of people actually fear and don't come for screening. The cost, low awareness, and a physician recommendation is the single strongest facilitator. Again, talking about United States, the disparities in insurance coverage and access, and the higher incidence and mortality was access in rural communities, and minorities present younger with few pack years, and yet they are less likely to qualify because they present younger, and the age cutoff being 50 and above. So these are the kind of gaps what the US has noticed. Because we don't have a screening program, we really don't comment on, we really can't comment on what are the gaps officially, but I will show you some gaps what we observe. Next, please. So what actually moves the needle according to US data, that is centralized programs and patient navigation, having dedicated coordinators tracking eligibility, ordering, and follow-up so that patients don't fall out of the pathway, and electronic health records where point of care prompts are given, and across the visits they are tracked, and improved eligibility capture in the society, and low dose ordering by the physicians. And there is a proof that there is a study called lung care study where shared decision making, where the physician or the coordinator explains what is the benefit of low dose CT screening. They saw they saw more referrals from the physicians to LDCT, and literally 13% was 32%. The number of people getting LDCT improved with the dedicated coordinators or doctors clearly explaining and spending time with the screening subjects. Next, please. So the evidence is settled. The gap is the frontier. 20 to 24% reduction in lung cancer mortality is offered by LDCT, and guidelines are widening, and yet only 20% are screened. And 8,70,000 life years are gained over 5 years if full uptake of screening is taken up. So the lesson here is screen the eligible, navigate the reluctant, and catch it early. So one more important thing, what the Indian scenario differs from US is, so the US screening high risk population is mainly based on cigarette smoking and pack years. Here there are two issues here. One, the air pollution, which is not taken into account. So that has to be taken into account. The indoor smoking, that has to be taken into account. And a lot of Indians smoke BD, and the packs might be different based on different manufacturers. Tobacco content is not fairly classified like a cigarette pack, because BD is a cottage industry in India, and it is not an organized industry like cigarette making. So the pack year eligibility and all those might not be really applicable to Indians. And also the biomass fuel also, which causes increased lung cancers in India, that cannot be quantified, and the exposure cannot be quantified. So does the screening recommendation, which cannot be based on a single cigarette smoking history. So these are the gaps, and I think the government has to work in that direction, define the scenarios where people are getting exposed, and then try to kind of develop Indian specific guidelines for the defining the high risk population in India. Next, please. So coming to the stage one, again, the organizers wanted me to discuss between sublobar resection versus lobectomy, and specifically the adenocarcinomas, which are peripheral in the outer one third and easy to resect. They do well with sublobar resections or segmentectomies compared to a lobectomy. And in select population, in JCOG, Japanese Clinical Oncology 802 published in the Lancet in 2022. Stage 1 segmentectomy versus lobectomy. The primary endpoints: superiority for lobectomy was meant, and better lung function preservation at 1 year, and local local relapses were higher with segmentectomy. And again, the sublobar versus lobectomy is only a standard if the selected tumor is less than 2 centimeters, peripheral 1/3, with a mandatory intraoperative nodal staging showing that the nodes are negative and the margins taken are greater than the tumor diameter. So these are the criteria which have to be fulfilled if a sublobar or a resection or a segmentectomy have to be done. Next, please. So what do the trials do and don't prove? JCOG was powered for overall survival and met superiority. CalGB tested disease-free survival and met non-inferiority, which is a lower bar than superiority. The OS edge reflects preserved reserve and competing risk, not better tumor control. So why I say that? Because the difference in OS, as they find out, the lobectomy actually the overall survival was better because not because of not because of the oncological superiority, but the deaths in the lobectomy arm were due to other causes. So again, local control, locoregional relapse roughly doubled with sublobar surgery, and this was shown in the trials. This demands more margins, that is margins greater than the tumor diameter. So the margins also should be more than 2 centimeters, and then we can favor anatomical segmentectomy over a wedge resection. And again, JCOG was an Asian trial, and they took the consolidation tumor ratio greater than 0.5. That is the radiological appearance looking more like more like tumor and less like consolidation. Then I mean the CTR more than 0.5 suggests more solid component in the scan, and EGFR rich population was selected. So both mandated again in operative nodal confirmation. So the bottom line and how I operationalize the evidence is segmentectomy is preferred over wedge for clearance. The margin should be greater than the tumor's diameter plus systematic nodal staging has to be done, and immediately convert to lobectomy if any nodal positivity is found intraoperatively. Next, please. So concluding, any node positivity on frozen, as we discussed, go for full dissection and lobectomy, and margin size less than the tumor diameter, extend the resection. Central tumors also, you need not go for you need not go for a complete pneumonectomy, but you can do a sleeve resection whose results are equivalent to lobectomy. Next, please. So the second topic what we discussed is SABR and surgery, stereotactic body radiotherapy versus surgery in operable lung cancer. Again, we have very limited evidence that stereotactic body radiotherapy is equivalent to surgery. Only a cohort of few patients, because there were phase 3 trials planned, but none of the trials actually got completed, and the recruitment was very difficult. Counseling a patient who's eligible for surgery for a radiation was very difficult throughout the world, and hence due to poor accrual, the trials did not go through. We have certain retrospective studies and non-randomized studies doing propensity matching surgery versus RT and telling that they are kind of equivalent. So finally, what do we have today is no adequately
Sorry to
powered.
interrupt, sir. So 2 minutes left for the session.
2 minutes.
Yes, so your session will start 7:50. We are
Okay.
8:05.
So 8:05, it is 20 minutes, right? 7 to
Yes.
7:20. Yeah. So 7 minutes.
Yeah.
Okay. So we have the final conclusion is no adequately powered randomized trial in operable patients has ever completed. That is there. So SABR shows excellent local control and genuine short-term safety, but operable comparison rests only on 58 pooled patients. Next, please. So equivalent is not proven, and surgery remains the standard of care for fit patients. We have to stage the nodes, and of course, for high-risk patients or surgery declined patients, high risk for surgery or surgery declined patients, SABR can be offered with good quality of life and disease control. Next, please. So immune SABR, adding nivolumab to SABR kind of improved the event-free survival from 53% to 77%, the 4-year EFS. So, but that is not again a replacement for surgery because we don't have phase 3 randomized evidence. But it's quite promising. Next, please. So finally, both sublobar resection and SABR, how are these? These are not equivalent. They answer different questions. For the fit patient, sublobar resection wins on nodal staging and tissue for adjuvant therapy. SABR is a parenchyma sparing choice when operative risk is prohibitive or surgery is declined. Tumor size and nodal certainty and pulmonary reserve and not preference alone should decide. Next, please. So step by step, first, to assess whether it is operable or not is the first step. Prove that it is N0 operatively and medically inoperable versus high risk or borderline. Just put him on SABR plus or minus immunotherapy. Next, please. So what each modality costs? Surgery 2% 30-day mortality versus less than 1% treatment-related deaths in SBR. Not a big difference actually. Next, please. So how I integrate SABR into early stage care in fit and resectable, still we operate. Only in high risk inoperable, we do SABR confidently. Equivalence has not been proven, and we have to await the randomized data. None of the trials could really accrue patients. Next, please. So again, I think my previous speakers have spoken at length about the adjuvant therapies, where we are doing all the full workup of EGFR, ALK, PDL1. Next, please. So adjuvant osimertinib, we've seen 5-year OS was 85% versus 73% in the ADAURA trial. And once EGFR is positive, the way to go for stage 1 to stage 3A is operate first, give osimertinib, chemo is not mandatory. Next, please. So we're really not sure whether osimertinib is just a cure or a longer leash. We do offer it, but in 1B, we have to weigh the risk versus cost. And DFS gains are dramatic, but the relapses accelerate once the 3-year course stops. Whether osimertinib eradicates micrometastatic disease versus merely suppresses it is unresolved. The OS benefit reassures but may reflect effective salvage as much as true cure. Next, please. So adjuvant Atizo, again, only in PDL1 positive population, showed a DFS benefit. Yes, we can definitely use it, and there is a direct proportionality with PDL1 positive. Next, please. So it is plainly for PDL1 positive people and skip if the driver mutation is present, and chemo is mandatory. First do adjuvant chemo, then only do atezolizumab. Next, please. So adjuvant Pembro, again, dual primary, it's a phase 3 trial again showing PFS irrespective of the biomarker. But again, there was a paradox where the PDL1 less than 1 and PDL1 more than 50 didn't do as much, had no statistically significant difference in terms of DFS. Only the PDL1 1 to 50 did well, but nevertheless can be used irrespective of the PDL1 status as the benefit was seen across the intent to treat population. Next, please. So this is the paradox what we were talking about. And hence, because of all this data, now the perioperative approach has taken precedence. Next, please. So again, ALK also, now we have data as elucidated by my previous speakers, and there's a DFS benefit for Alina. And MET, the problem is the Libretto trial, the problem is we don't know the duration of selpercatinib. Either it can be used till progression or for 3 years. But the benefit is definitely seen. Next, please. So adjuvant nivolumab and durvalumab have not shown any benefit. Next, please. So neoadjuvant nivo plus chemo, the Checkmate 816 has shown PCR 24% and a 5-year OS benefit of 65 versus 55%. The only trial to show OS benefit in the neoadjuvant setting. Next, please. So definitely we favor neoadjuvant when because we know that the PCR is translating into 5-year OS now, and but we don't. But the only problem is 75% don't achieve PCR. We don't know what to do in the adjuvant setting for those who don't do PCR. That is one of the caveats of this trial. Next, please. So perioperative pembro, again, PCR is 18%, cross-trial comparison, but comparatively less with less compared to nivolumab. But there is an adjuvant strategy, and it worked out well. Next, please. So definitely we go for Keynote 671 for all the perioperative cases. But again, we have to, I think, use MRD to escalate or de-escalate the adjuvant strategy, where PCR achievers will de-escalate, and those who don't achieve PCR should be escalated treatment, but that has not been done in this trial. Next, please. So again, perioperative durvalumab also showed benefit, but lesser PCR compared to its peers. So maybe we have better options than durvalumab in this setting. Next, please. So next, please. In the overall survival is also not there yet. And checkmate 770 also we needed a discussion. So PCR was 25% as discussed previously with 816. And now we have the adjuvant too, but we really don't know how much the adjuvant is driving the survival. But even in N2 nodal, that is stage 3B, also showed benefit with was the data was reported particularly in this trial that N2 also showed benefit. Next, please. So yes, where do I use 816 versus 7070 in the 25% to achieve PCR today? I'll stop it by doing a MRD maybe and stop there. Versus who didn't achieve PCR, I'll just continue nivolumab. Next, please. So we have data from NeoTorch which showed perioperative toripalimab in NSCLC, and there is a trend towards OS and very good PathCR rate of 20, PCR rate of 25%. And next, please. So it's promising, but again, generalizability unproven because it's a single country trial. Majority were squamous, and majority of the population was Chinese. Next, please. So again, tislelizumab by far has the highest PCR rate of 40% and a MPR rate of 56.2%, with EFS HR showing 0.56 and overall survival showing 0.65. But again, same, it has the similar problems with toripalimab, where majority were Chinese and squamous. Next, please. So next, please. Again, we've discussed, I think, all. So best approach, stage 1 surgery, and stage 2 biomarker decides, and resectable stage 3. I think perioperative approach is what we tend to do, and test everyone, and accordingly, biomarker negative versus biomarker positive, we'll decide what to do first. Next, please. Thank you. So catch it early by screening, and let the biology, not the habit, choose the therapy. Screen the eligible, resect with intent, and personalize the cure. Thank you.
Thank you, sir. Thank you for a wonderful presentation. We now move to our next session. It's my pleasure to invite Dr. Rekha Bansal, Consultant Medical Oncologist, Apollo Hospital, Hyderabad. Ma'am, over to you.
Thank you. Thank you. Thanks a lot. And thank you for agreeing to swap my session. It's just that I'm just getting too many phone calls from the hospital. I'm just trying to share my screen ASAP. Thank you, Suresh sir, for the opportunity. So just a minute. Uh, is my slide visible?
Yes, ma'am, visible.
Thank you. Thank you so much. So there's almost a renaissance like moment when it comes to the treatment of SCLC. We have moved from chemotherapy to immunotherapy and now even beyond, which something which was unfathomable when it came to SCLC. So whenever a patient is
Ma'am,
diagnosed with,
sorry to interrupt. Ma'am, can I request you to share your screen in presentation mode?
yeah, it does this work?
Yes, perfect.
Yeah, thank you. Sorry about that. So sorry about the delay. So when it comes to SCLC, we know how although the NSCLC, the counterpart of it, is so exciting. There is so much going on, and we just had a very extensive talk learning about how even in the neoadjuvant, adjuvant immunotherapy is making a difference. But when it comes to SCLC, we rarely have so much to talk. Of course, already the incorporation of immunotherapy in first line was a game changer, and now we are looking what more can be done. So Empower 133 and Caspian are already standard of care, and we also have real world data backing it's the same, which has shown comparative outcomes. Now lurbinectedin has moved to first earlier it was only a second line option, but now with IM4 data, it has moved to a maintenance paradigm. Again, we also have the option of tarlatamab, which is actually a bispecific DLL3 and CD3 bispecific. We will try to look into the mechanism, efficacy, and toxicity. And we'll also talk a little bit about the role of PCI and role of molecular subtyping. For the want of time, I've kept my presentation really simple and short. So although we are all talking about different domains about what is the first line, the first line backbone would be the immunotherapy, and then we are trying to reset the maintenance options by adding lurbinectedin to the already existing immunotherapy backbone of maintenance, and we are now discussing about the second line options in this case. So for 30 years, there was a lull. There was nothing happening. We were only relying on platinum and etoposide. And then in 2019, first, when IMpower 133 data came out, it was approved. Atizo and carbo etoposide was approved. And then the Caspian data, based on which durvalumab along with PE was approved in 2020. Second line approval of lurbinectedin came in 2020. Now in 2024, there is tarlatamab accelerated approval, and then the traditional, the full approval came in 2025. So we have moved a lot from the chemotherapy backbone to now using immunotherapeutics with a very distinct mechanism of action, something which was never thought of in this disease earlier. So when we talk about the IMpower 133 and the Caspian, we have the mature overall survival data. IMpower 133 gave a median OS of 12.3 months versus 10.3 months, and a 3-year OS rate of 3-year OS rate of 16% when compared to 6% in the chemotherapy arm, with a hazard ratio of 0.76. Caspian had very, very comparable numbers and hazard ratio of again 0.71. So consistent OS hazard ratio across the two independent chemo IO trials, 16 to 18% 3-year OS in the immunotherapy arms, which is very durable tail, which we rarely saw since before 2019, and 5-year Caspian data where durvalumab continues to show a survival plateau when compared with chemo alone. Even in the real world, right, trial from cohorts from US, EU, and Asia, they have given similar outcomes, though slightly the trial numbers might be slightly behind the real world numbers might be slightly behind the trial numbers. So let's talk a little bit about the maintenance data now. So IM4, where lurbinectedin was added to atezolizumab in the maintenance after the initial induction. So the patients were randomized to receive 4 cycles of chemo with IO induction, followed by either atezo alone maintenance versus lurbinectedin plus atezo. And addition of lurbinectedin gave a median OS of 13.2 months when compared to atezolizumab alone, and this is statistically significant, both PFS and OS, leading to the regulatory approval. And, so this is again unheard of, but adding lurbinectedin, definitely it comes at a cost. The toxicity is definitely more. We know it is an alkylating agent and it can cause chemo-like toxicity. But all said and done, it is something to look for. And if it can give us a OS of 13.2 months, definitely we would want to use it. So it all started from a basket trial where it was a single arm phase 2 trial where overall response rate was. So it has moved from later lines to the maintenance line. Earlier in the basket trial, it was giving an overall response rate of 35% with an median OS of 9.3 months, which led to the accelerated approval. And then we have the phase 3 Atlantis trial, which did not meet the primary OS endpoint. Real world outcomes, whether it's in second line or third line, it is almost giving a median OS of 5 months. And it does have a CNS activity. As we know, the intracranial PFS in patients with baseline brain mets was 3.1 months versus 8.8 months without the brain metastasis. So, although it had a single agent second line salvage role, it has moved from that to now a maintenance option. So now let's talk about the tarlatamab, which is a very unique bispecific. It is like a bridge. It is a bridge between the patient's immunity and the tumor cells. So we all know that DLL3 is expressed in SCLC. Almost, I think, 85 to 90% of the tumor cells express it. So there is no need to check. It is a near universal target in SCLC, and it's basically Notch pathway ligand. So DLL3 and CD3 bispecific, which is the bridge between these two, thereby activating the T cell, leading to tumor cell lysis. Based on the Delphi 301 phase 2 study, there was accelerated approval in May 2024. This bispecific gave a overall response rate of 40% and median OS of 14.3 months, median PFS of 4.3 months, and duration of response of 9.7 months. When we looked at the Delphi 304, where tarlatamab was compared with standard of care chemotherapy. Now, in this standard of care chemotherapy, there was most of the patients had got topotecan. I think only about 47 patients got lurbinectedin, and then some patients got ambirobicin. It was based on the investigator choice, and there was benefit even in this chemo-resistant subset, and even in patients with, I think, 47 patients in either of the arms had brain metastasis. And so there were, of course, we are concerned about the AEs with tarlatamab, but they are manageable. And grade 3, more than grade 3 AEs were fewer discontinuations were also seen with tarlatamab. And there was significant patient-reported outcomes were also better with the tarlatamab arm. So it is also now approved second-line option after progression with a platinum-based regimen. So tarlatamab, because it activates the T cell immune system, it has unique toxicity like we see with other drugs in the class. It can cause the cytokine release syndrome. This is the most common AE, but it's mostly grade 1, and it requires proper monitoring of the patient during the first cycle and the second cycle for at least 24 hours. And then it can also cause the immune effector cell associated neurotoxicity, but of course this is less than CRS. It generally is low grade and it presents as confusion, tremor. It's rarely severe. Of course, it can also cause hematological toxicities. So toxicities are reversible, and definitely this puts tarlatamab as a favorable option than compared to lurbinectedin in the second line option. I think we always debate about whether PCI should be given to all the patients or should we just put them on observation, and only when we see something, then we should probably give the cranial irradiation. So prophylactic, we have data from EORTC trial where PCI was not mandated. Sorry, PCI versus observation was looked at, and PCI definitely improved the survival. And we also have the DCOG trial data where MRI baseline was mandated, but PCI didn't add any OS benefit. So because we don't have data head-to-head comparison between tarlatamab and lurbinectedin, how do we counsel the patient? I think it is needless to say tarlatamab has definitely shown better response rates. The toxicities are manageable even in that subset which are rapid progressor, that is chemo-resistant subset, where progression happens in less than 90 days. There is also tarlatamab has shown a benefit even in active and treated brain metastasis, and the toxicity is manageable. But when it compared to lurbinectedin, I think toxicity is one major problem. And yes, of course, it can be given on OP basis, but it only works when patient has a platinum sensitive relapse. So I think definitely chemo IO combination remains the first line backbone, especially with the backing real world data. And IM4 repositions lurbinectedin to an earlier line rather than the second line salvage line. And tarlatamab is now confirmed phase 3 second line option, and it has a distinct toxicity profile. But I think we will learn as we use it more. PCI versus MRI surveillance, I think the debate will persist, and MRI surveillance is a reasonable option. Molecular subtyping, where we are looking for ASCL1, NeuroD1, PO2, F3, SCLC-I. This is prognostic and it is only trial relevant as of today. Thank you.
Thank you, ma'am. Thank you for those insightful presentation. Next, we move on to the final discussion. Our final speaker, Dr. Avinav Devan, medical oncologist, Rajiv Gandhi Cancer Institute and Research Center, Delhi. Sir, over to you.
Yeah, is my screen visible?
Yes, sir, visible.
Yeah. Yeah. Good evening, everyone. Thank you, Suresh sir and IAIO for giving me this opportunity. The topic of today's discussion is targeting resistance. My focus will be on EGFR mutation. Yeah, as we know, EGFR mutations are one of the commonest mutations seen in non-small cell lung cancer. Exon 19 and L858R account for almost 70 to 80% of the EGFR mutations. The standard of care treatment includes osimertinib, which is a third generation EGFR TKI. And nowadays, combination regimens like FLAURA2 and MARIPOSA have also shown improved OS and PFS versus osimertinib monotherapy alone. And as it has been seen that novel approaches like a combination therapy of FLAURA2 MARIPOSA can help us delay or prevent acquired resistance by prolonging the clinical benefit and by proactively targeting the downstream resistance mechanisms. I will go on to the next slide. If we talk about the phase 3 MARIPOSA trial, there was a role of EGFR MET bispecific antibody amivantamab that was combined with lazertinib in 1,074 patients with EGFR mutant metastatic non-small cell carcinoma. This trial comprised of 3 arms, that is Ami-Lazi versus Lazi alone versus osimertinib in the ratio of 2:1:2, and showed a significant PFS and OS benefit in favor of the Ami-Lazertinib arm. Based on the above results, the FDA approved amivantamab and lazertinib in August 24 as the first line therapy for EGFR positive non-small cell lung cancer. Analysis of the paired ctDNA samples showed that fewer patients in the amilazi arm than osimertinib had emergence of EGFR resistance alterations or MET amplifications. That is, proactively targeting downstream resistance mechanism in the first line setting could actually improve the outcome and alter the observed pattern of resistance. These were the common side effects that we come across when we use amivantanib, that is paronychia, rash, infusion reactions, dermatitis, stomatitis, and so on. Thus, while prescribing treatment for EGFR mutant metastatic non-small cell cancers, in the first line, careful discussion of monotherapy versus combination therapy is essential. Strong consideration of osimertinib chemo versus ami-las for patients motivated to maximize efficacy at cost of greater potential of side effects is necessary. And nowadays, we also have subcutaneous formulation of amivantanib to obviate the infusion reaction and reduce the thromboembolic events. Now, coming to the topic proper, what are the various mechanisms of acquired resistance to osimertinib? Now, these mechanisms of resistance can be classified into EGFR dependent, that includes EGFR amplifications and C797S mutations. Then we have EGFR independent mechanisms that include oncogenic fusions, MET HER2 amplification, downstream pathway activations, and cell cycle gene alterations. Third one is histological transformation. And fourth, the most important one is unknown mechanisms. As we can see, these unknown mechanisms of resistance account for almost 50% of the resistance cases. Acquired resistance mechanisms may be subclonal, potentially limiting their therapeutic applicability. Yeah. So what accounts for this high proportion of unexplained resistance? That is technical limitations, non-gene level changes like epigenetic alterations or protein overexpression, and tumor heterogeneity. Even in the clinical trial setting, sample quality, availability, or assay limitations often prevent resistance mechanism testing also. This is our RJCI data of last 5 years, in which almost 226 patients were given osimertinib in the first line, out of which 129 patients had progressed. 86 patients had pathological confirmation of progression, and NGS was obtained in 58 patients. And if you can see, this figure shows the various pattern of mutations of these 58 patients. C797X mutation was seen in 7% cases, EGFR other mutations in 5%, EGFR copy number gain in 12%. MET amplification, which is one of the commonest acquired amplifications, was seen in 16% of the cases. The full paper of this data is presently under consideration in a journal. These are the NCCN guidelines. I will just move on. So what happens when the disease progresses on first line EGFR TKI, that is osimertinib? First thing that comes to our mind is repeat a biopsy to rule out histological transformation. And based on the histology, we can plan the chemotherapy regimens. And of course, as we know, once the transformation occurs, the outcomes are very poor and treatment options are limited. Second option which we come across for treating these patients are, we should continue osimertinib beyond progression. And the COMPEL study actually compared osimertinib and combined it with chemotherapy versus chemo alone in patients with progression of EGFR mutation without any CNS disease progression. So it was seen that there was significant median PFS and OS survival was seen in favor of the osimertinib and chemotherapy arm. And thus it suggests a clinical benefit of continuing osimertinib with chemo as an alternative to chemo alone. Coming to targeting MET and HER2 amplifications, as far as we know, for MET amplifications, MET-specific TKIs, MET-specific ADCs are available. For HER2 amplifications, we have options of HER2-directed therapy, TDX3, TDM1, pertinu-directed TKI zongertinib is also available nowadays. As far as the MET-directed therapies are concerned, there was one phase 2 study that combined afatinib with chemo followed by afatinib and pemetrexed maintenance and showed a PFS of 8 months. The next one is the Savannah trial that actually combined a MET TKI inhibitor savolitinib with osimertinib and showed an overall response rate of 56 months with a PFS of around 7 to 8 months. There is one INSIGHT study that combined tepotinib with osimertinib and showed, if you can see here, showed a response rate of almost 50% in MET amplified patients. This is another combination of savolitinib plus osimertinib. This was versus chemotherapy. And this also showed a favorable outcome in favor of the MET and EGF osimertinib combination. Coming to Mariposa 2. Mariposa 2 is the combination of amivantamab, lazertinib and chemotherapy versus chemo alone and versus amivantamab and chemotherapy. Amivantamab, as we know, is a bispecific antibody and has shown significant improvement in PFS and OS in favor of the combination arm versus chemotherapy. Can I request everyone to kindly close their mics? And as per the Mariposa study, median PFS outcome were better with the in the combination arm, regardless of the osimertinib resistance mechanisms. That is, this regimen worked in unknown resistance mechanisms also and showed significant improvement in PFS and response rate in comparison to chemo alone. Palmoa 3 again compared subcutaneous AMI versus IV amivantamab and showed showed a favorable safety profile in comparison to the IV amivantamab. Immune check inhibitors alone in combination with chemotherapy has not shown any significant improvement in PFS or OS. The next approach to overcome the resistance is we can try combining immunotherapy with anti-angiogenic agents. This IMpower 150 study used the ABCP regimen and compared it with Bev, Pacli Carbo and Atezo. ABCP was compared with Atezo, Carbo, Pacli. And it was seen that in EGFR mutants patients, that is number was 123, there was significant improvement in median OS in comparison to chemo alone, chemo plus Bev. And there were certain other trials that try combining immunotherapy and anti-angiogenic agents with chemotherapy, which showed improvement in PFS. So this recently, this drug has been developed, that is evonesimab, that is a novel version of combination of immunotherapy and anti-angiogenic agents. It is a human tetravalent bispecific antibody that targets the PD-1 as well as VEGF-A. And this drug showed a significant improvement in median PFS when compared to chemotherapy alone. And there was a trend towards survival benefit also in the combination arm versus chemotherapy. And this was the Harmony study. And most recently, there are various phase 1, phase 2 studies of ADCs in osimertinib resistance cases. As we can see, this datoderoxeticin has been FDA approved for EGFR TKI resistant cases. This patritumab deruxtecan was initially also received accelerated approval, but has been recently withdrawn. There are various other ADCs that are undergoing trials, that is saxatumab, govitecan, tirumotecan, and so on. This is a Harthena trial that was a single-arm study that compared HER3 DXd and showed a PFS rates of 5.5 months and response rates of 30 months. Harthena Lung 02 trial compared HER3 DXd with chemotherapy. However, it achieved a PFS. There was no OS endpoint could not be achieved. And finally, coming to the Tropion Lung 05 and Tropion Lung 01. There was a pooled analysis of Tropion Lung 05 and Tropion Lung 01 in which Dato-DXd was compared with the chemotherapy, that is docetaxel, and showed significant improvement in PFS and response rates. And FDA has approved Dato-DXd based on this pooled analysis. There was a response rate of 45% and duration of response was 6.5 months. So based on the data, we of course have the option of using Dato-DXd, which has better results and better survival as better results and response rates and PFS in comparison to the chemotherapy alone. Again, for the newer ADCs like saxatumab govitecan, OPTROP Lung 03 study has also shown significant improvement in response rates and PFS in comparison to chemotherapy alone. This newer drug, Isabren, has shown response rates of 58% post TKI use and is undergoing trial in the first line setting also. And if you see, there is an overall response rate of almost 100%, nearly 100% with this drug. These are the PFS of various trials in a tabular form, in a graphical form. And finally, coming to newer agents like fourth generation EGFR TKIs that target the triple mutated EGFR gene like DEL L858R, T790M, and C797 mutations also. This is another Blue 945 is a fourth generation TKIs that have shown PFS benefits. These are some other studies that are noting down efficacy of fourth generation TKIs. So if we talk about patient with brain mets, we always have an option of using either SRT, whole brain RT, FLAURA2 is of course there, MARIPOSA2, use of drug ivonescimab also has intracranial efficacy. So excellent intra and extracranial control can be obtained with combination regimens beyond osimertinib. Those patients with co-mutations respond well to ami-lazertinib combination, saffron study, and MET-directed therapy are also useful in these. Of course, role of liquid biopsy has been discussed by Dr. Sabina in the previous lecture, so I will just skip it. If we look at this, the EGFR mutant non-small cell resistance mechanisms can actually be classified into MAP signaling pathway depending on the MAP signaling pathway and the plasticity pathway. And in the MAP signaling pathway, in the first line, ideally if ami-lazertinib or dual MAP kinase inhibition have been used. In the second line, we have option of combining osimertinib and osimertinib also, and fourth generation EGFR TKI. While in the lineage plasticity resistance mechanisms, OSI chemo plays an important role in the first line setting. And in the second line setting, we have options of Dato-DXd and chemo amivantamab combinations. This is just a brief diagram that shows for the on-target resistance mechanisms, what options we have. Fourth generation TKI, dual EGFR blockade, including OSI and geftinib, then osimertinib and PDK inhibitor. For the EGFR independent mechanisms we use for MET amplification, OSI MET inhibitors are used. HER2/neu amplifications, we have HER2/neu targeted agents with OSI. ALK activations, we can combine OSI with ALK inhibitors, and AXL overexpressions are also there. And lastly, for the small cell transformation, we have option of chemotherapy. However, results are quite poor with traditional chemotherapy regimens in histological transformation, and newer agents like ADCs plus osimertinib chemoimmunotherapy are also being tried in this setting. And I'll just skip this. Newer agents, other novel strategies like radioligands, EGFR protein degraders, and other newer agents are coming and undergoing studies at present. So these are the two important slides. Just to conclude that a minority of resistance to first line osimertinib can be attributed to acquired single gene alterations, and resistance appears to be driven by either MAP dependence or plasticity. If an acquired alteration is identified, outcome appears better. The most frequent alteration we know is MET amplification, which can be addressed with a combination of EGFR TKI and MET TKI. If amivantamab has not been utilized, it is active with chemotherapy or in combination with EGFR TKI as per the Mariposa study. Dato-DXd has been approved by FDA and can be used in unknown mutations also. And for histological transformation, traditional small cell directed therapies may not be so effective. So when resistance to first-line osimertinib occurs without any identified resistance mechanism, what is your next step? As we know, biomarker-driven approaches are not feasible in this setting. We have option of systemic chemotherapy, Mariposa 2, IMpower 150, COMPEL trial, Harmony study, Dato, ADCs, and Orient study. So to summarize this thing, for unexplained EGFR TKI resistance, that can be identified in 50% of the patients. Even if my mechanism is identified, it may not be actionable. So standard of care after progression remains chemotherapy. Unexplained resistance limits the biomarker-driven approaches. Resistance gap should be addressed with strategies that have broader mechanism of action, and expanded testing is required. Combination regimens like Mariposa, Harmony, COMPEL can help in improving the outcome after EGFR TKI, and ADCs offer a new avenue for patients with unexplained resistance. And finally, the last topic, that was the KRAS G12C inhibitor. The comparison of sotorasib with adagrasib. This was the last part of my talk, that is comparing the half-life, clinical trial, line of treatment, dose, median PFS, overall response rates. They are more or less comparable. Potency is better for sotorasib. Sotorasib has better intracranial efficacy and favorable GI toxicity profile in comparison to the adagrasib arm, and chances of treatment-related adverse events were more with the adagrasib in comparison to sotorasib. Thank you.
Thank you, sir. Thank you for beautifully presenting this session. So, as we conclude today's session, I would like to sincerely thank our program director and our esteemed faculty member for sharing their outstanding knowledge and clinical expertise. And I also extend my heartfelt thanks to all the participants for joining us and making today's program interactive and successful. On behalf of IAIO, thank you for being with us. Have a wonderful evening, stay safe, and we look forward to welcome you to our upcoming IAIO academic programs. Good night, everyone. Thank you.